Thank you, Ted. Appreciate it, and I appreciate everybody joining the GMN sites today. Um, I've been instructed to go through a series of accreditation slides, so I'm going to scroll through these fairly quickly. And Emma, maybe if there's new folks who are joining, you can add the appropriate links for claiming CME credits in the chat or something. But
Okay.
here are the options for doing that. And then the last slide on this series is my disclosures, and this isn't really relevant to my discussion today, but I do have a research grant that's funded by Roche Diagnostics. So what I wanted to do for today's topic was to talk about uh, what else is there besides Alzheimer's disease. Sometimes I think we talk about dementia and Alzheimer's and almost like they're synonymous. And so this is reflected in the questions that we get in clinic and probably in the public when we do presentations out in the public. A lot of times, always, we get the question, what's the difference between Alzheimer's and dementia? And that question comes up all the time in my clinical practice. And so this is kind of how I imagine people receive the information. If I tell them that I think they have mild cognitive impairment or dementia or Alzheimer's, well, mild cognitive impairment, that probably doesn't sound great. Dementia really doesn't sound good. Alzheimer's, that's bad. And so I always have to explain what these terms mean. And and of course, mild cognitive impairment and dementia are really a description of symptoms, and they're very similar to one another. In fact, I've started to question the continued value of using the term mild cognitive impairment as opposed to just different stages or levels of cognitive decline or impairment that is on the spectrum for all dementing illnesses. And these two terms are essentially referring to the same set of symptoms of cognitive decline and sort of progressive functional limitation, the main difference between the two being severity. So this is really on a continuum of normal cognition all the way to what people often imagine when they hear Alzheimer's, which is terminal stages, very late stages of dementia, is really on a spectrum from normal to terminal in any dementing condition. And the only difference between MCI and dementia is really in terms of severity. And so these are just symptoms of a disease. And so this is a slide I use when I do talks in the community. And I used to use different ones. And you can come up with any number of them. And so when you say my stomach hurts or I have a stomach ache, that's not a disease. You're just describing a symptom. But then, if you imagine what you look like right after Thanksgiving dinner, your stomach might not have felt so good because you ate too damn much at Thanksgiving. Or it might be because you have a peptic ulcer and you've got a hole being eaten through your stomach or upper GI lining. Those are very different causes of stomach ache. And so when we talk about MCI or dementia, we're saying, that it's equivalent to saying I have a mild or severe abdominal pain, and then the causes are the gastric ulcer or indigestion or whatever. And so the difference is the symptom versus the cause or the disease itself. And so when we talk about age-related cognitive decline, Alzheimer's disease and dementia and MCI due to Alzheimer's disease is the most common and accounts for probably about 65% of age-related cognitive and functional decline. But, that leaves a lot. And so there's a big chunk of individuals who have decline because of ischemic damage or stroke and vascular cognitive impairment. There's a spectrum of diseases involving alpha-synuclein, which are characterized by abnormal deposits of alpha-synuclein in Lewy bodies and Lewy neurites that we'll talk about. And then there's a group of disorders called frontotemporal dementias, which is actually not a single disease. It's not a single pathology, but it can be associated with different inclusions, including MAP-tau as well as TDP-43. And so those are all the different those are the different causes of cognitive decline and functional limitations. And so I wanted to spend a few minutes today with the opportunity to talk about these other conditions. So one frequent misperception by patients is that you can see these things. So when you do an MRI scan, they think that you can actually specifically diagnose Alzheimer's disease or other causes of cognitive decline based on MRI scan. There are things that we can see on MRI, and we do this routinely as part of our clinical evaluation because we can see things that provide us insight into what's going on. And here, what I'm showing are a series of FLAIR images from 3 different MRI scans with different severity of microvascular change. So this particular set of images, the FLAIR sequences, are really valuable for us in evaluating people who have neurologic problems, because it just shows us some beautiful, really exquisitely sensitive images of certain things. And so what we're seeing here are different severities of microvascular change. So, we've talked often about vascular dementia, and our understanding and definitions of vascular dementia have sort of evolved over the years. When I was in training a long time ago, we used to think of stepwise decline associated with discrete large vessel ischemic strokes and a series of strokes causing vascular dementia. But really, in our clinical practice, when we're evaluating people with cognitive concerns, it's much more common to see individuals who have small vessel disease. And this is something that is seen very well on MRI scans. And these panels on the right actually show what these imaging findings on MRI look like at pathology. And what you're seeing is these whitish patches on these histological stains are showing areas where there's been ischemic damage. And so this is something that we do see very well on MRI scans. The other thing that we can see on MRI scans are patterns of atrophy. So these images on the left are individuals at different stages, primarily of Alzheimer's disease, although it may not be Alzheimer's disease, but Alzheimer's disease very often is associated with selective degeneration and atrophy in the medial temporal lobes in the hippocampus and entorhinal cortex. And you can see the going from normal to severe atrophy in the medial temporal lobe structures. Those changes are also quite apparent on MRI scan. And then in frontotemporal dementia or frontotemporal lobar degeneration, you can see either lateralizing or focal atrophy in certain areas of the brain. So these areas that I'm circling here, there's an intrinsic symmetry in the brain. So you can see that there is an inherent sort of abnormal pattern of asymmetric volume loss here. And then in the right hemisphere versus the left hemisphere here. So we can see these patterns of neurodegeneration, and they can give us some insights, but this is something that we tend to see late. And so what don't we see? So early on in degenerative diseases, the MRI scan is typically normal. So in many of our patients that we're evaluating who have significant cognitive impairment, their MRI scans may show minimal microvascular changes, but no other really significant structural abnormalities on MRI. And all of these pathologies that we associate with specific diseases, including Alzheimer's disease, are not visible on MRI scans. So how do we know what it is? So this is a slide that I first created many years ago for medical school lectures. And so when we evaluate patients who come in with concerns about cognitive impairment, we always look at certain things. Obviously, we don't want to miss untreated depression or severe depression that may be either causing or contributing significantly to cognitive decline. And then there are a series of things that we do. Blood tests we do almost as a knee-jerk. We look at B12 thyroid in almost every condition. But there are blood tests that can give you insight into medical conditions and also potential sources of delirium from medical conditions always have to be considered because remember the syndromes of mild cognitive impairment and dementia require that the conditions be persistent, and that is to specifically exclude transient confusion associated with delirium. And then we do structural imaging, and that's what I was showing with MRI. And so things like vascular cognitive impairment or sometimes ventriculomegaly associated with hydrocephalus or other structural abnormalities can be seen on structural imaging. But in terms of the broad spectrum of neurodegenerative age-related cognitive decline, we assess those and diagnose those based on patterns. And one of those patterns is based on neuropsychological testing, patterns of impairment on cognitive measures, and then clinical features supplemented by biomarkers where they're available. And then those are the primary things that we do in order to do the clinical diagnosis, the clinical sort of discrimination of underlying causes of cognitive decline. And there are many, but we'll focus on some of the more common non-Alzheimer's causes of age-related cognitive decline. So what is the pattern recognition? So this is no different from any other area of diagnostic decision making in medicine. And we learn to recognize patterns in different areas. And within the clinical history, these conditions can have a lot of overlap. I'm going to show you a couple of cases coming up, and you'll see that there may be overlap in terms of the types of symptoms people describe across these degenerative conditions. But there are certain features that are more typical. So for Alzheimer's disease, because the most typical feature is short-term memory loss, repetitiveness or misplacing things, forgetfulness is very common. In patients with dementia with Lewy bodies, there are some major disruptions in terms of sleep and level of consciousness and awareness. With frontotemporal dementias, the features can vary, but sometimes there may be behavioral features that are most prominent. So you might hear about disinhibited behaviors or withdrawal as a prominent part of the history. And then in progressive supranuclear palsy, which is really a variant of one of the forms of frontotemporal dementia, because of the area of the brain that's affected, people may have a lot of gait instability. And so the most prominent historical feature may relate to mobility changes or falls. But then, other things, difficulty managing, job responsibilities, mood changes, driving, personality changes. These things can occur historically in all of these conditions. So you kind of start to discriminate, well, what features are more typical of one versus another? In the general neurologic examination, one of the things about Alzheimer's disease is it's pretty boring. So when I have learners in clinic with me, the general neurologic examination in Alzheimer's patients with mild cognitive impairment or mild dementia is usually normal because the areas of motor control are not typically affected. Whereas with dementia with Lewy bodies, we may see very significant prominent Parkinsonian features. In PSP, because again, the distribution of the pathology in the brainstem, there are oculomotor features that are very characteristic that PSP is probably one of the easiest clinical diagnoses to make. And I'm not going to talk a lot about this, but this is really valuable because when you see PSP and you diagnose it clinically, you can be very confident that what you're dealing with is an underlying tauopathy, so a tau variant form of frontotemporal dementia. And then for motor features and other types of frontotemporal dementia, there may not be a lot except for the paucity of movements associated with withdrawal and some personality behavioral changes. And then lastly, in terms of the neurocognitive features, again, I mentioned memory is usually the hallmark feature, but not always in Alzheimer's disease. And among patients with Lewy body dementia, visual hallucinations is one of the hallmark features. So very prominent, well-formed visual hallucinations is a major indicator of underlying DLB. With PSP and other forms of frontotemporal dementia, there may be more of an executive or primarily language dysfunction. But then in certain features of frontotemporal dementia, the neuropsychiatric features may be behavioral changes. I mentioned disinhibited behaviors, and other personality and behavioral changes may be most prominent. So those things can overlap, but again, there are certain features that lend themselves to sort of diagnostic discrimination based on pattern recognition. And then we use biomarkers primarily in Alzheimer's disease. In early stages, we don't have great biomarkers, imaging or biofluid biomarkers for non-Alzheimer's dementias. But by looking at these markers, so we do spinal fluid measurements of amyloid and tau, which are hallmark features of Alzheimer's disease. And those do a very good job of ruling in or ruling out Alzheimer's disease based on spinal fluid biomarker testing, and also increasingly now based on amyloid PET scans, which are being covered by Medicare and insurance, so this becomes more accessible. And so here, what we're looking at, the injection of amyloid tracer that will actually pick up and demonstrate the presence of amyloid pathology in living individuals. So we can use spinal fluid measures and amyloid PET measures to either rule in or rule out Alzheimer's disease. And then when we've ruled out Alzheimer's disease, that actually helps in terms of discrimination, because now you've eliminated one of the major components that may be a consideration, one of the major diagnostic considerations. So let's talk about a couple of cases. So this is a 76-year-old white gentleman, retired mechanic, who came in to see us, and one of his prominent complaints from him and his wife is that he's been acting out dreams. She abandoned him and ditched him because she got tired of getting beat on during the night. But then during the last couple of years, he's been having more difficulties with cognitive changes, and then developed these visual hallucinations where he was typically seeing people. Oftentimes people will report seeing people or children or animals are very common. And so he was seeing people in their home. And another interesting feature about this is that this patient, as many others, if their spouse or somebody else says, "No, there's nobody there, honey. This is another one of those times when your eyes are playing tricks on you," they're quite accepting of that. And initially, these visual hallucinations were not terribly disturbing, and these are very much visual. So typically, there are no auditory or tactile associations with these hallucinations. But it was the same large man and woman that he would see in their bedroom, but then it became more threatening to him. So initially, we weren't treating this, but it started to become more frightening. And the large man that was showing up started wielding a large knife. And this patient also had some symmetrical rigidity and slowness. So again, this is one of those cases where the Parkinsonian motor features, unlike traditional Parkinson's disease, in Lewy body dementia, these tend to be more rigidity related and slowness related rather than tremor related. And whereas idiopathic Parkinson's disease is almost always asymmetric, with Lewy body patients with Lewy body dementia, it tends to be more symmetric. And these are just some gross images of the midbrain. So this is the substantia nigra, which has these pigmented neurons that you see. And in patients with Parkinson's disease, these pigmented neurons tend to be lost. And so you have this depigmentation in the substantia nigra. And within the nigral neurons, these Lewy bodies, these accumulations of alpha-synuclein occur in these dopaminergic neurons in the substantia nigra. In patients with Lewy body dementia, you get the same deposition of alpha-synuclein, but in dementia with Lewy bodies, that pathology is also distributed cortically, so not just in the midbrain, although there can be involvement of the midbrain. but cortical Lewy bodies. And patients who have Parkinson's disease who develop cognitive decline. So there's something called Parkinson's disease dementia, which is used to describe patients with idiopathic Parkinson's disease who for many years may just have typical motor features, but then 10 years in, they start developing some cognitive features. And when you look neuropathologically, those Parkinson's patients with cognitive involvement typically have cortical Lewy bodies as well as brainstem Lewy bodies. But this is the same alpha-synuclein. Why it manifests differently in Lewy body patients versus Parkinson's patients is not entirely clear, but clearly those diseases are linked by underlying pathology. My second case is a 77-year-old retired businessman who, again, he came in with his primary complaint being of memory loss. But by the time he came in, it was mostly driven by behavioral changes. So he had become increasingly disinhibited, was confrontational with his wife and with strangers. He was obsessively working out at the gym. He was a very fit 77-year-old guy. Frighteningly, he owned a bunch of firearms, and he started routinely carrying. And this was before we had everybody can carry a concealed weapon in Georgia. And he started traveling with handguns in his car. He was going to the skeet range and shooting. He's convinced that he's going to be in the next Olympic Games for skeet shooting. And his wife moved out because she was afraid for her safety. On his examination, he had profound memory loss. So again, a strong overlap with other degenerative conditions, including Alzheimer's, but he had zero insight into what was going on. He also had a pretty profound loss of recognition. So this was really interesting. He couldn't recognize pictures of the presidents. He didn't recognize Osama bin Laden, and this was like a long time ago. So Osama bin Laden was very recognizable, and he, and during his hour-long visit, he repeated that the same half dozen stories about boxing and skeet shooting and driving fast cars on Georgia 400 the whole time. So really peculiar behaviors, but very atypical features in terms of the history, in terms of behaviors. And this was his MRI scan on sagittal images, and this is an allegedly normal brain. This is my brain at about the same level of cut on sagittal. And what you see here is this profound loss of anterior temporal lobe structures as well as inferior, and then some, if we saw more of it, superior temporal lobe atrophy. So very severe focal atrophy in this patient, essentially making a diagnosis using MRI in a relatively advanced stage of disease of somebody with frontotemporal dementia. And so that's what he had. But one of the things that is really kind of murky and challenging about frontotemporal dementia is that it can manifest very differently. So some of you may have seen patients who present with something called primary progressive aphasia, where their primary symptom appears to be mainly expressive language problems. And really, the majority of those cases that we see that present that way are atypical forms of Alzheimer's disease rather than frontotemporal dementia. But some patients with sort of focal left frontal atrophy may present with just a progressive language problems. But depending on where the focal damage and lateralizing damage occurs, in the dominant hemisphere tends to be more language-based, expressive or semantic dementia. And then on the non-dominant hemisphere, more behavioral and personality changes. And of course, there can be multiple combinations of these. And so the manifestations clinically of frontotemporal dementia is quite complicated, can be quite complicated. And partly the reason for that is that the pathology is very highly variable. So what we're seeing here on the left are different patterns of tau inclusions, MAP tau, the same tau that is accumulating in Alzheimer's disease, but here without the accumulation of amyloid. And there are molecular differences that we won't go into on the types of tau inclusions and the cell types that accumulate these tau inclusions. But another large percentage, maybe even half of frontotemporal patients don't have tau pathology. They have TDP-43 pathology. And in many cases, you can't really discriminate based on clinical features, which are tau-based and which are TDP-43 based, and we don't have any good biomarkers of those things. And so these are places where we still depend very much on our clinical impressions in making those clinical diagnoses. Now, in terms of how to treat these patients, ironically, although patients tend to be most frightened of a diagnosis of Alzheimer's disease, if you had to pick a degenerative dementing illness today, I think I would pick Alzheimer's, especially if I was being caught at very early stages, because that's where we've made the most progress in terms of treatment. But the strategies for all dementing illnesses is going to be exactly the same template. Because the problem with these conditions is not in early stages. Early stages, symptoms may be very mild and quality of life may be excellent. But in later stages, when you have more profound decline in functional abilities, is what people imagine when they hear Alzheimer's. And that's the same end stage of any of these conditions. And so the strategy that we've now started to implement in Alzheimer's disease are disease-modifying strategies to slow progression so that we give people a chance of dying of whatever they're going to die of before they ever get to those terrible late stages of disease. And then as we advance in Alzheimer's and all of these neurodegenerative diseases, the idea is to come up with these disease-modifying therapies and apply them earlier and earlier until we're delaying and preventing. And so in terms of strategies, these other non-Alzheimer's dementing illnesses have really lagged behind, but that's where we're headed. And then the last thing I want to just comment on is there's a new report from the Lancet Commission. Every several years, they release a report on modifiable risk factors. And the most recent amended version is pretty interesting. So early life now refers to up to 18 years of age. So we've known for a long time that education is very important for age-related cognitive abilities. But the biggest changes really were here. And so in midlife, in the 2020 version of the Commission report, hearing loss first showed up as a major contributor, as a modifiable risk factor. And this now, remember, the age range for midlife used to be 45 to 65. Now we're talking about 18 to 65. And so during adult life, starting from very young, we need to manage these things. Cholesterol is now showing up as a major modifiable risk factor starting from very young age. And then mood disorders, traumatic brain injury, inactivity, diabetes, smoking, hypertension, obesity. And I don't know about you guys, but I was kind of happy to see alcohol dropping down the list a little bit. But excessive alcohol, again, is still a contributor. And then in late life, something that we've all been sort of increasingly concerned about, social isolation and people in elderly individuals, and then air pollution exposure, again, appears to be a significant contributor to late life cognitive decline that's modifiable if we can sort of clean up our act. Visual loss is a new addition to this one as well. But add those up, and potentially even without treatments, drug treatments, potentially 45% of late life dementia can be avoided altogether with appropriate lifestyle interventions. So that's all I've got today. I think I'm right at 12:30, so I apologize I didn't leave any time for questions, but I appreciate you all spending some time with us for this GM Insights.
Hey, thanks so much, Dr. Law. We got lots of great comments. I got several sent to my text about the great job that you did, so thanks so much. Dr. Steve Patton wanted to know, found your diagram very helpful where you have the overlay between PSP, AD, and frontotemporal dementia. And so if we can get a copy of that to send out, that would be great. I know that when we look at a PDF of your slides, those are all collapsed into one figure slide on.
Yeah, I can actually, what I can do is I know the animations messed up the PDF, so I will redo those animated slides so that they're more viewable and share that with you and Emma.
Hey, I appreciate that. Hey, I have a quick question for you, and that is this phenotypic recognition. Way back in the day, they used to say that vascular dementia had a stepwise pattern of decline. And what's your experience today in this day and age? And do you see that, or is that indistinguishable with these microvascular changes?
Yeah, so I've always sort of wondered the what we would see, and I think it's very different. I think if we were in stroke clinic and our
Right.
stroke neurologists have started doing more cognitive screenings, I think in stroke population you would see that sort of stepwise decline. But in the geriatric population, it's much more common for us to see cognitive decline related to microvascular accumulation of microvascular changes. And when those occur in isolation, it tends to be a much more benign process. It can be progressive, but I view it as a more benign process, and the concentration really should be on managing risk factors and employing lifestyle interventions. One thing I did not, I took out of one of my slides is actually the fact that these various causes of dementias don't typically occur in isolation. So vascular changes especially can coexist with a huge proportion of Alzheimer's disease. And so sometimes it's very difficult to separate out the contributions from different pathologies. And at least half of Alzheimer's patients who have typical amyloid and tau also have TDP-43 and alpha-synuclein inclusion. So those are some of the nuances of mixed dementias that the field is wrestling with right now.
Thanks so much for your blood work, your TSH and CBC and metabolic panel and syphilis and HIV. Are you surprised by any of those values that come back, or do you recommend those for completeness sake?
I mainly do those for completeness sake. You know, it's pretty uncommon for me to find anything. I can't remember the last time I actually diagnosed somebody with a subacute combined degeneration from pernicious anemia and serious B12 deficiency. I have had two that I can recall over the last quarter century, but it's almost sort of kind of dotting I's and crossing T's. Certainly, hypothyroidism or even hyperthyroidism can be a contributing factor. And so we always want to look for these things that may be contributing. But it's very rare for me to find something in the blood work that gives me an etiology. Sometimes with HIV-associated neurocognitive disorders, so people who are long-term HIV survivers that are well managed, that's something that I see periodically. And again, we don't have a great diagnostic marker or test, but oftentimes when older HIV patients in their late 60s or early 70s now that I'm seeing who've had HIV for many years, I will often wind up excluding Alzheimer's pathology because otherwise the features cognitively may be very similar.
A question from Sonia Green. Besides for potential of new therapy for Alzheimer's disease, does your management of dementia change by the types that you were talking about? Typically in primary care, we do not have a definitive diagnosis. I know that that's also a plug for Stephanie Viverberg's handout based upon differential treatment by disease, but I'll give you a swing at that too.
Yeah, so there are some so for many cases, no, but because we advise the same lifestyle interventions, the same healthy diet, exercise activities, engagement, social engagement for everybody, whether you're sick or not, as you're middle aged and in later life. I think all those things are important. But there are some nuances. So, for example, patients who have dementia with Lewy bodies may be exquisitely sensitive to Parkinsonian features or side effects of certain medications. Just like people who have Alzheimer's and Lewy body dementia both have significant cholinergic deficits, and so they may be particularly sensitive to anticholinergic side effects. And so there are some nuances. But in terms of availability of medications, for the most part, with the exception of cholinesterase inhibitors proving to be beneficial in patients with Lewy body dementia, we don't have proactive drug therapies for these non-AD dementias. And so we're really kind of playing from behind because we're reacting to symptoms as they emerge. But early on, the recommendations until target symptoms emerge are generally similar sort of lifestyle advocacy and things like that.
Super lecture and presentation, Dr. Law. Really appreciate you. Hey, thanks everybody for joining us. I put some information in the chat about where to find the first part of this lecture if you missed it, or other lectures that you might have missed in the past. Text for your CMA credit. Great to see you, and we'll see you in the new year. Thanks again.
Bye.